I think the Philemon trial really brings up a very interesting proposal, which is to really skip chemotherapy and move on to a non-chemo approach, really combining the most effective drugs, which is an anti-CD20 antibody, ibrutinib, and lenalidomide. And both of these compounds have long-term remissions, so it's very temptive to really combine both of them. What about the results? Well, I think the response rates are quite satisfying. They're in the range between 80 and 90%. And of course, this is a phase 2 trial, so we have to be a little bit cautious. And of course, it all depends on the duration of remission, which is the much more important information for our patients. So far as it looks like we can achieve long ongoing remissions, and it might be even better than what we achieved with ibrutinib only. So I think the next logical step is really to consider these kind of combinations in first-line treatment of at least some of our patients with mantle cell. Well, it's obvious that one would probably assume that you go for the less aggressive cases, which is essentially not the ones, the blastoid, not the ones with Ki67 above 30%. This would be probably too risky, at least for first line, for relapsed, though this is a totally open question. This is a huge step, but that's the next logical step. Now we got this mono therapy experience where we achieve high response rates in the range of 80% or so. Combination, as been explored by the Philemon trial, is the logical next step. And now we really have to figure out the optimal combination and, as you were referring to, the optimal setting for our patients.